So we're going to be talking about the digestive system today, or the gastrointestinal system, and it's basically one big long tube. Okay, done. Everybody go home. No, I'm just kidding. Right? What gets a little crazy is as that tube goes down, it takes different shapes and forms. In addition, the lining is different, the outside is different, the muscle is different. Okay? There's a lot of things that happen along that tube. In addition to it being a big long tube, we also have organs that are kind of hanging off of it that help with digestion, immunity, okay, and the general overall functioning of the body. The biggest thing that the digestive system will do for us is do what? Digest, right? We're going to absorb all of our macro and our micronutrients from the GI tract. What's the difference between macro and micro? I got up this morning and I had a bowl of oatmeal, and then I took my vitamins. Which one's macro? Oatmeal. Which one's micro? Vitamins and minerals. We go over that next week in metabolism. I just want you to have the gist. All of those substances will be absorbed along the GI tract. I'll tell you where they get absorbed specifically in a little bit. Okay? What else is absorbed? It's a major nutrient from the digestive tract. Begins with a W. Water. Okay? The major solvent of the body. And we do other things in the GI tract, but that's one of its main functions. All right? Now, the other interesting thing that the digestive tract does is it's a huge part of our immune system. What? Why would it be a huge part of our immune system? Or actually, I should say, contributor towards immunity. It's not a part of the immune system, per se. What do you think happens when you go to the cafeteria and you ingest food? What else are you ingesting? Bacteria, viruses, right? So your digestive tract has several things that help to prevent those from being absorbed. Are you with me? Okay. One of the concepts that students have difficulty with that I want you to think about, and once I say it, it'll make sense. The GI tract is exposed to the external environment. Now that I've said it, it makes sense, doesn't it? Right? Can I not take my finger and go right into my mouth and theoretically go all the way through until you know where, right? So it's exposed to the external environment. That's why it has such a strong immune response to external pathogens, right? Are you with me? Okay, does that make sense? Okay. So, digestive system. Okay. Also known as alimentary canal. Can you guys read this okay? I feel like it's dimmer today. Oh, you know what it is? Hold on a second. Does this help? Yeah, okay. Okay, there we go. Okay. So we've pretty much gone over, I gave you kind of the once over explaining this. One of the concepts I want to talk about is, okay, the GI tract is about 30 feet long in a cadaver, but it's shorter in the living. For a Hershey kiss, who could tell me why? Oh, she won. Okay, see me at some point in lab, I'll give you a Hershey kiss. Tonicity. What is tonicity? It's that slight contraction of the muscles so they are ready to respond at all times. Okay? The accessory organs, who could give me an example of an accessory organ in the GI tract? We actually just went over one in endocrine. The pancreas, because it has exocrine as well as endocrine functions. We're going to talk about those accessory organs along the GI tract and how they help us with digestion. Okay? Do you remember the serous membranes? Told you these come back to haunt you. What are serous membranes? Yes, she's going like this. They cover and line different organs in the chest and abdomen, right? Okay. We're going to talk about the serous membranes that are in the abdominal cavity. They're very important. Does anyone remember what serous membranes do for us? Yeah, they secrete serous fluid so we don't rub our tissues together, right? What else do they do in the abdomen? They help to, you can actually absorb some fluid through the serous membranes, yep. They help to hold certain organs in place. I'm going to show you exactly how in a little bit. Okay. Along the abdomen or within the abdomen, we need some organs to really stay in place and some others we need to move. Like think about the GI tract, the small and the large intestines. What do we do with food in our GI tract? We churn it, right? Those need to be able to move. So these serous membranes provide some anchoring in different amounts to keep organs in place. Okay. Digestive process, I feel like this is kind of common sense stuff. We're going to zip through it really quickly so we can move on to the more difficult concepts, okay? We ingest, repropulse, or move it along. That process, everyone's heard of that, right? It's called peristalsis. Is that a one-way thing or is that a two-way thing? It's a little bit of a trick question. Everybody's like, oh, I'm not going to answer it now. Okay, for the most part, foodstuffs is going to go one way, hopefully, right? Because if it's going the other way, right? But we move stuff a little bit forward and back. Why would we move it forward and back in short amounts along the GI tract? What are we trying to do to it? Take out all the nutrients. Back when we were cavemen, we got food. We wanted to suck all the nutrients we could out of that, right? So our bodies have sort of built in this way of churning the food just a little bit front and back to get all the nutrients out of it.
Would that assist in like vomiting? Or?
What happens with vomiting is a reflex the other way. And we actually, it starts well, it's pretty gross. I've seen physiological videos where it actually starts in the intestines and it pushes it back up. You asked. You asked. Okay? But in normal digestion, we're going to keep it going the other way. But yes, that's what I was referring to earlier. Okay. Mechanical digestion, I think that sort of makes sense. I'm going to talk to you about segmentation, which is that churning in the intestines in a few slides. Chemical digestions, we're going to deal with enzymes. There's different enzymes that are released from different areas along the GI tract, actually starting in the mouth. And I'll give you a list of them at the very end of this lecture that help to break foodstuffs down. Okay? Do you remember... I think we should go over this briefly. Even though we're doing metabolism next week, let's review, excuse me, the major macronutrients. Can anybody rattle those off for me? Because we're going to be talking about the enzymes that break them down. Where do you get your energy from with your macronutrients? Glucose, and glucose would be begins with a C. Carbohydrate. Hold on a second. Okay. Okay, carbohydrate. So carbohydrates, an example of carbohydrate, and we're going to go into more, would be glucose. And carbohydrates are used for what? Energy. Okay? And we're going to go over this completely next week too. Excuse me. Who can tell me what the second macronutrient is that we can use for energy among other things? Fats. Fats are known as lipids. Okay, so this is our secondary source of energy. Is it as efficient as glucose? No, it's about half as efficient. Okay. What's our third macronutrient? Protein. And proteins are going to, and keep in mind lipids do things other than energy, guys. Okay, a lot, okay? And proteins create a lot of the structural aspects of our body. So when we eat a hamburger with carbs, lipids, and proteins in it, do we turn into a hamburger? No, of course not. Our body has to do what with those macronutrients? Got to break them down. They've got to be broken down into subunits that we can use for energy, secondary forms of energy. This also creates hormones, cell membranes, etc. Okay, or structural units of the body. Okay, does that make sense? Okay, more about that next week, but I want you to have the basics of that because we're going to talk about the enzymes that break them down. Excuse me, a little tickle my throat. Okay, absorption obviously and defecation is the elimination of feces. Okay, so, serous membranes, right? Oh, serous membranes. So what happens with serous membranes in the intestines is basically embryologically when you start to grow, you grow into them. Your organs too, okay? And if this is a serous membrane that's going to be around part of my GI tract, are you with me? So it's a flat sheet. What happens is parts, not all of the GI tract, grow into these serous membranes, and what happens in the back? The serous membranes closed. So some, but not all, are completely covered with what? Serous membranes. Are you with me? And then the free edge actually goes back onto the abdominal cavity and around the abdominal cavity. Are you with me? Does that sort of make sense? Okay. Some do this, right? Where the serous membrane actually adheres to the back of the abdominal wall, and this is actually true of the kidneys, not really the GI organs, but it's the same serous membrane, so I want to talk about it here. So if I push this serous membrane back and I'm a kidney, are you with me? Am I in the serous membrane? No, I'm behind it. Are you with me? So some organs go in, some organs stay behind. Are you with me? The ones that go in, I was like, oh, I hope I'm on the right side, are called peritoneal organs. They are in the serous membranes. Peritoneal, okay? Or intraperitoneal. Most people say peritoneal. It's on the bottom of your slide there, okay? If I don't get covered in them, I am behind. What happens when you go to a store that's retro? It's things that are behind the times, right? Retro means behind. Retroperitoneal organs are ones that don't get covered in those serous membranes. They stay behind. Why the dickens do I make you learn this? What can you get? Suppose you get stabbed and you get God forbid, and you get an infection into your abdomen. You get peritoneal infection or a retroperitoneal infection. Do you see what I'm saying? They're subunits of the abdomen. So you'll need to know what organs are which. Are you with me? Does that make sense? Okay. Everybody's having a hard time waking up today. So I have one of my silly sayings for this. I'm going to give it to you now and you go over it in lab. Kidneys ascend and descend. Did you guys already do this? No. Okay. Down the pike. These are all your retroperitoneal organs. Kidneys, ascending, colon, descending, colon, Any guesses on this retroperitoneal organ in the abdomen? Duodenum or duodenum? Okay, how do you say that, Dr. Hochberg?
I'm Midwestern. I'm
Duodenum? You're duodenum or duodenum?
I say duodenum.
Duodenum? So do I. Okay, we'll go with duodenum. But you know what the nursing staff says, duodenum, I believe, yeah. Anyway, all right, sorry, I didn't mean to interrupt, but I was curious about that one. Pancreas. So these are, once again, all of your, what? Retroperitoneal organs. So liver, what is that? Retroperitoneal or peritoneal? Peritoneal. Transverse colon. Peritoneal. Sigmoid colon. Peritoneal. And the reason I give you this mnemonic is because when we look in the abdomen of the cats, it's not going to be like, oh, that looks peritoneal and that looks retroperitoneal. It doesn't. Some of them push through, just like I showed you with the scarf, some don't. So this is a great way to remember which ones are retroperitoneal. Okay? Any questions on that? Now there's things, oh, and to review, do you remember this terminology? Visceral and parietal peritoneum. Oh, let's review it really quickly. I'm sorry, excuse me. When we talk about the organs versus the body wall, if I cut open my abdomen and roll open the sides, visceral peritoneum is the serous membrane that is on the organ. Parietal peritoneum is the serous membrane on the wall. Okay, that's all that means. Okay? So visceral versus parietal peritoneum. Now mesentery, and I showed you earlier how it wraps around. On the stomach, so if you imagine my arms, the stomach, we actually have what's called a mesentery hanging down off the stomach, okay? So hanging down off the stomach, the two sides of the serous membrane join together. And they form this kind of apron that's called the greater omentum. So when we open up the abdominal cavity of the cat, you're going to see a big fatty pad in there. Don't rip it out. Everybody rips it out unless I tell them not to. It's actually the mesentery. It's a specific mesentery, I should say, called the greater omentum. And that greater omentum hangs down from the greater curvature of the stomach. It has blood vessels, it has lymphatics. It can actually fight small infections if we get them in the abdomen, okay? I've actually read that it'll move a little bit if there's an infection. Who knows if that's been verified or not, okay? But that's an important thing to know about it. But the other thing that's important to know about it is we can deposit fat here. And if we deposit a lot of fat there, what is that called? Abdominal or truncal obesity. Why clinically is that important? Does anybody know? We had a cadaver, you know, I worked at MBCC with the cadavers before I came here. And we had a cadaver who was skinny as all get out, except for his stomach. And when we opened up his stomach, his greater omentum, I am not kidding you, there's hair in there, was that thick. Well, guess where else he had a lot of fat? Nobody? No? No guesses?
His heart.
Yeah, his heart. His heart was encased with fat, and his blood vessels sounded like that. That truncal obesity or that abdominal obesity correlates strongly with fat around the heart and the arterial system. Okay, there's a strong correlation with that. Okay, so if we deposit it into that greater omentum and it's stored there, we're probably going to have more fat around our hearts. Okay, all right. Any questions on these serous membranes? We're good? Great. Stop me anytime. Okay. Peritonitis is if we get an infection there. The problem when we get an infection there into these serous membranes is that we can't release the appropriate amount of serous fluid. So we can get friction between them. I had an infection in my abdomen years ago, and I'll talk to you about it in a little bit actually. And let me tell you, there is no greater pain than abdominal pain. When you have an infection in there and you decrease those serous fluids and they start to rub together, very, very painful. Okay. So blood supply. The way the blood supply works, let's go back to drawing this really quickly. What's the main artery that comes down off the heart, through the diaphragm, and into the abdomen? You better answer this one. The aorta, good. Okay. So the aorta, we have the arch, and then we have, when it's in the thorax, thoracic, right? And then it passes through the diaphragm and it becomes the abdominal aorta. Very good, before it splits to the common iliacs. Other than knowing these blood vessels coming off, why is it good to know the location of the abdominal aorta? What can we get here? If it expands, what's that called? Aneurysm. I would review that. Abdominal aneurysms are very dangerous. We did that in blood vessels. Please review that. Good clinical stuff to know, guys, okay? All right. So, coming off the front. So this is a little different from blood vessels we've seen before. It's almost like a little stoplight. Because these three branches are singular. Celiac trunk, superior mesenteric, and inferior mesenteric are singular, right? Every other blood vessel, for the most part, we've seen have been what? Bilateral, okay? And these simply are just the different branches that go to the different parts of the GI tract. Celiac trunk's at the top. It goes to gastric, hepatic, and splenic. What's the translation of that? Gastric would be stomach, hepatic would be liver, and splenic would be spleen, okay? Underneath that is superior mesenteric. Write this down. It goes along the whole, and you don't know the parts, so just write it down and it'll make sense when you go back to review later. Are you with me? Superior mesenteric is going to go from duodenum to transverse. Can you guys read this? I hate this chalk. Transverse colon. Can you read that enough for superior mesenteric? Hello? Yes? Okay. Okay, so superior mesenteric is going to cover all of the tube from duodenum to transverse colon. We'll learn the steps in just a little bit. Okay. Inferior mesenteric will go from transverse colon to rectum. So basically the rest of the tube. Okay. Okay. Are you with me? We're going to learn those steps in just a little bit. Kind of put the cart in front of the horse with that one. Sorry about that. This provides the blood supply to the GI tract. And then we will have similarly named veins draining those areas. Okay? Does it make sense? Yes? Okay. Now, hepatic portal circulation. I know everybody's a little tired, so turn on your thinking caps here for a minute. Okay. Hepatic portal circulation. I'm going to backtrack a little bit. So I ate some oatmeal this morning and a banana, right? I eat that food, it goes into my GI tract, it gets broken down. what's the next step in the small intestines? What do we have to do to it? We have to, somebody just said it, absorb the nutrients from my GI tract. Are you with me? So I ate my food, chewed it up, used some enzymes, broke them down, got it to my small intestines. Now we're going to start absorbing. The hepatic portal system is a series of veins that drains nutrient-rich substances into the bloodstream, right, into these veins, and it sends it to the liver. Are you with me with that? Everybody's so tired today, aren't you? It's like, okay, so hepatic portal circulation will drain that nutrient-rich substances, put it into the blood, and send it to the liver. Okay, and then the liver's going to do a bunch of fun stuff we'll talk about in a little bit. Okay. So the arteries that we just spoke about provide the blood to keep the GI tract healthy and renew its own tissues. The hepatic portal circulation will bring the nutrients from the GI tract to the liver. Yes? Can you envision that? Can you picture it in your head? All right? Okay. Obviously, this will increase after a meal, the hepatic portal circulation. Any questions on that? Okay. Now, let me see what that is. Okay, we're going to talk cellular. I know you love that, so we'll spend a lot of time on it. I'm just kidding. When we're looking at the GI tract, what happens, let me chew this up, is the cell types and layers go from a protective layering in the mouth and the esophagus into one cell layer thick. So let's talk about that first, briefly, because I can kind of summarize the whole GI tract for you. Okay. What type of epithelium do we remember provided protection? We have it on the surface of the skin. Stratified squamous. Inside the mouth and the esophagus, we have that same protective stratified squamous. Think about it. Think about all the chewing I just did, chewing up that little cough drop. If I did that with a single layer, what would happen to that layer of cells? Oof, right? Be gone. Okay? So stratified squamous from mouth to the esophagus. The esophagus will then connect with the stomach. Okay? At that point, it turns into a simple columnar. And we're going to look at all of these steps, guys. I'm just trying to give you a once over. Simple columnar goes all the way down through the GI tract, large intestine, small intestine, all the way down through the rectum to the anus. And at that point, from the anus out, is stratified squamous. Okay? So stratified squamous in the beginning, stratified squamous at the end, simple columnar along the rest of the way. The simple columnar looks different from place to place, but that's the general gist. Why would we want a simple columnar along the GI tract? It can absorb nutrients, and also what happens in the stomach. We're secreting as well, right? Like hydrochloric acid, okay? So secrete and absorb, okay? So stratified squamous, simple columnar, stratified squamous. Yes? Are we good with that? Okay. And some variations. Looking at a cross section of that tube. Okay, here we are back to the tube, right? Is this going to be exposed to this opening or lumen of the tube? Going to be exposed to the external environment? Absolutely. Remember what I said, that little example I gave of me using my finger, right? Okay. So here's the lumen. This would be your mouth, right? Food would go in and go into the tube, or the lumen. Do you guys know that lumen is another word for an opening in a tube? Okay. And if you remember from A&P1, a mucous membrane is exposed to the external environment. A serous membrane is not. It's encased in the body. Do you remember that? Okay, that'll make 2 layers super easy for you. The inside layer is Tunica MucoSE. Excuse me, the outside, if we have one, some places don't, let's just pretend they do, is going to be Tunica SeroSE. Okay, Tunica MucoSE on the inside, Tunica SeroSE on the outside. Are you with me? Okay. Tunica MucoSE is going to have the epithelium that we spoke about. Okay, so let's take a look at those. Tunica MucoSE, innermost layer. We're going to have different epithelium. We're going to either have stratified squamous or simple columnar, which we spoke about. Now, in this simple columnar, we will have, I'm going in my brain, I'm like, he's not a student of mine, a student that just came in. Like, maybe he's in a different lab. Did he make a funny face before he left? Did he? Poor kid. He thought it was a different room. That was pretty smooth though, just, you know, in one door and out the other. All right, so anyway, Tunica MucoSE. Interspersed along the simple columnar, we're going to have goblet cells. Do you remember what goblet cells are and what they do? They are a unicellular exocrine gland. I just heard that. Excellent. Exocrine gland that secretes mucus. As we get further down into the colon, we'll see more goblet cells. Okay? The reason you'll see more goblet cells as we get to the end of the colon is because we take water out of the foodstuffs in the GI tract and we need that mucus to lubricate feces passing through. Gross? Yes. Necessary? Yes. Okay? So goblet cells. And do you remember what those goblet cells look like? If you've got the simple columnar, they're interspersed between those cells. We'll look at those in lab. Okay. Lamina propria, is kind of this loose connective tissue that holds that epithelium down. Okay. It has some white blood cells to fight infection. I'm going to talk to you about that in the future as well. And then there's a Muscularis mucosa, which is just a small, smooth muscle layer, which can help some of the movement of the cells on the surface. I read somewhere that it might have some contributed peristalsis, but don't think of it that way, okay? Tunica SubmuCOSE is going to be where? Just, it's not a trick question, just underneath the mucosa, right? Submucosa is going to be the layer that's just underneath the mucosa. Okay? Thanks for coming.
My pleasure, thank you.
We'll see you later. Okay, so submucosa is going to be the dense connective tissue layer that's underneath the mucosa. All right? Somebody out there, you guys are tired? You guys tired? Yeah. Me too. Sorry. It'll have blood vessels, lymphatic vessels, and nerves in it, okay? There's some elastic fibers in the stomach, but the submucosa is also important. We're gonna see there's collections of white blood cells in parts of the GI tract in the submucosa. They're called Peyer's patches. It's right in the notes, okay? But if you just keep in mind that it's just under the mucosa layer, and it's brilliant, really, to put white blood cells there, right? Because if we start to absorb substances that are infectious, we can fight them off, right? Tunica Muscularis is the next one out. It's going to be a layer of circular, I think we have a picture of those different circular cells and longitudinal cells, okay, in the muscularis, Tunica Muscularis. Why do you think, from what I've told you already, that you have different directional fibers in this smooth muscle? And it's smooth muscle, do you remember that? Okay, smooth muscle we have in the GI tract. Why do you think you have the fibers, or the cells I should say, facing different directions? We spoke. I'm sorry, what?
Is this so you can like contract?
Yeah, the longitudinal, if you imagine, move this way. So they're going to create that process of peristalsis. The circular ones go this way, and they will push it a little bit forward, and a little bit back, and a little bit forward. It's almost like when you push the toothpaste in your tube, right? You can kind of push it up. Well, you want to go both ways, but the circular layer does that kind of compression, and it churns your food, so we can suck the nutrients out of it, okay? So longitudinal and circular. The circular layer can also come in to form a sphincter. We're going to have sphincters in more than funny places. Did everybody just giggle in their heads when I said sphincter? A little bit? It's okay, right? We have them like on top of the stomach, right? And they just pull in tightly, and we can control their opening or closing. So it's important to understand the concept of the sphincter. Okay. Tunica SeroSE is going to be the outer portion of these 4 layers. Okay. This would be the visceral peritoneum that we've spoken about, the serous membrane on organs. Are you with me? Another word for it is mesothelium. I'll never ask you that, but just to be complete, okay? There are some places where we don't have this serous membrane, such as the back part of the esophagus, where we don't have the back part, or where we don't have these serous membranes. It's called an adventitia. It's basically a connective tissue instead of a closely packed cells. Okay. Now, retroperitoneal have both the SeroSE and an adventitia. That seems a little confusing, but do you remember when I did this? Right? So retroperitoneal organs are touching the serous membrane in the front, but not in the back. They have a loose connective tissue in the back. That's what that means, okay? Does that make sense? We good with this? Yeah? Okay. Any questions so far? Beautiful. Okay. One more slide and we'll take a quick 2-minute break. Okay. So the enteric gut nervous system is super interesting. We actually can function, our gut can function without our brain. We have reflex arcs in our gut that will keep digestion going even if we cut our vagus nerve. I think it's pretty cool. But anyway, that's why these terms have come up, go through gut, or it's because it has its own little brain. It's pretty interesting, okay? And the way that it's subdivided is sympathetic will slow digestion, parasympathetic will increase it. Okay, do I have that up there? Yes, okay. Okay, so parasympathetic will increase it, sympathetic will decrease it. And what happens is those nerves from the vagus nerve come down to the GI tract and split. Okay, and they'll form plexuses. There's one in the submucosa, and there's a enteric, which is between those 2 layers, longitudinal and the circular. So if you were to cut into those layers and you looked in the submucosa, there'd be a bunch of nerves that span out. And if you looked between those circular layers, there'd be a bunch of nerves that span out and innervate all those cells in the GI tract. Are you with me? Okay. And there'll be some sympathetic fibers in there as well. Okay. The submucosa is going to focus more on glands and muscle control in the mucosa, and the enteric is going to focus on those muscular layers, okay, and help those to function. Does that make sense? Yes. Okay, let's all go get some caffeine. So now kind of the function. So we're going to kind of do the form and the function together. Okay? Looking at the mouth, we're going to look at the space behind it. There's something called the pharynx. The pharynx is the common tube through which air, food, and water pass. Behind the mouth itself, that part of the tube is called the oropharynx. And the nose is the nasopharynx. In front of or next to the larynx is the laryngopharynx. It's in the notes. It's in the notes. Okay? But the pharynx is that common tube before we split to the trachea and the esophagus. Okay? Stratified squamous epithelium, we already spoke about that. Lips are also known as labia. I would never ask you that. But I would ask you about the palate of the mouth. There's a hard palate, which obviously would have what underneath it? You don't put your tongue on the roof of your mouth. That's what underneath this. Yeah, it's bone. Okay. In the front, it's maxillary bone. In the back, it's palatine bones. Is that in there? Yes. Okay. So know the bones. The important reason, or the reason I tell you about the bones, is because they can separate at birth. That's called a cleft palate. And the maxillary bone is first to be open. We'll do this at the end of the lecture. But I'm just telling you why I'm teaching the hard palate. And then it could actually go all the way back to the palatine bones. And the reason, other than looks, it's important is a child can't suckle with a cleft palate. Think about it. They don't have that closed, right, to suckle. So that needs to be surgically fixed. The soft palate is your uvula, or that little punching bag in the back of your throat. Okay? Any idea what that does? Your uvula? There's a gag reflex from the cranial nerves. Very good. Did you ever have that kid in high school that could spit milk out their nose? Okay, that's because they can hold their uvula back. Your uvula covers the back part. You know it's open, right, between your nose to your throat. Your uvula covers that when you swallow. Oh, that's why you have it. Okay. No, you guys never had a kid that would do that? No, maybe I don't know. I grew up in a weird time. We were bored in the 80s. What can I say? Anyway. Right, so the soft palate is going to be the uvula and the skeletal muscle that's back there. The tongue is skeletal muscle, and it goes in multiple directions, so you can move your tongue in multiple directions and turn the food that you're eating. That little piece of mucous membrane that you can see on the bottom of your tongue that goes this way is called your lingual frenulum. That's important to know because some children are born with it too close to the tip. And if it's too far forward, they actually can't lift their tongue up once again to suckle enough. They used to clip it. I hear now that they're letting it go unless it becomes a real big problem. Okay, so lingual frenulum. Papillae of the tongue, we're going to go through this really quickly because I believe we did this previously. I used filiform, fungiform, and circumvallate. Okay, foliate are the ones on the side. I don't go over them just because I don't, okay? Filiform create the roughness of your tongue. They do not have papillae. Fungiform and they cover the whole surface of the tongue. Fungiform look like little mushrooms. That's why they're called fungiform. And they're interspersed on the surface of the tongue. You can actually see them if you look in the mirror at your tongue. See little round dots. Those are fungiform. Circumvallate are on the back of the tongue. They form a V, and there's 10 to 12 of them. Both fungiform and circumvallate, which are also known as vallate, have taste buds on them. Am I going too fast? I'm kind of buzzing through this because we've already done it. All right? Okay. Now, behind the circumvallate, we have the lingual tonsil, which is not papillae. Okay, it's a tonsil. It has white blood cells to help protect infectious agents coming in. Deal? All right, any questions on this? Salivary glands, they're help to clean the mouth. They're a mixture of serous and mucus fluid. Just know that. You don't need to know this crazy. One is serous, one is mucus, one is mixed. You don't need to know the difference. Just think of them as contributing a mix of serous and mucus fluids. There's parotid, submandibular, sublingual. And they all have ducts that go into the oral cavity to provide fluids. Now these fluids do a multitude of things. First and foremost, they'll provide some fluid to add water to our food to make it easier to digest. They have enzymes, and they also have antimicrobial agents in our saliva. Okay. I've got a list of those in a little bit. Parasympathetic would increase the production of those fluids. Sympathetic decreases it. This is why we get a dry mouth when we're nervous. Now, mumps, which we don't see mumps anymore, do we? Why don't we see mumps anymore? You probably just had it.
The vaccine.
Mm-hmm. A very effective vaccine against it. What could happen in some cases, it's like 25% of the time, is if you did get mumps, it affects that parotid gland, but in males it also affects the testes and it could cause sterility. This is one of the reasons they work so hard at getting the vaccination. Okay, I did a little reading online and it's actually very few cases. So, but still, mumps is a very yucky disease that we don't want. So it's a good thing that we have a vaccine against it. Okay. Teeth. Kids or deciduous teeth in kids, we have 20, or they have 20. And as we get to the adult and grown teeth, we have 32, okay? I really don't go a ton into teeth. You know, I'm not going to ask you the different types. I think we all kind of know incisors, canines, premolars, molars, done. I'm not going to ask you about them. What I do think you should know is the inside structures, some of them. You've got the enamel on the outside, which is one of the hardest substances, if not the hardest substance in the body. Provides a nice firm layer on the outside. And the root, I think it's important for you to understand that the root has arteries, veins, and nerves in them. If these get disrupted, the tooth can die off, and that's where they end up giving you a root canal. So I do think it's good for you to know that on the inside of the tooth where the root is, that you have artery, vein, and nerve. Okay? I think it's also good to know that they'll be embedded in the mandible and the maxilla. Okay? I know somebody who actually had bone wear away in her mandible and her maxilla to the point where she started to lose her teeth. And they actually had to extract all her teeth and put in false ones because they were so loose and they were getting infected. And that's why it's important to take care of your gums and your teeth. They think that she got an infection because she hadn't seen the dentist for like 10 years. So it's important to have that visual to how the tooth is embedded into there. And yes, it is important to go to your dentist regularly for that reason. Okay? But other than that, I don't ask a bunch about the anatomy of the teeth. I would only ask about what little I just mentioned to you. Okay? So a root canal, death of the nerve, or really it could be a death of the cutoff of the blood supply, can cause a death of that tooth. Okay? The tooth is a living thing that needs to be regenerated, so they would have to go in and do a root canal to fix that. I don't know how they do it. Dental caries, we call them cavities. If you get a sugar that eats through the enamel, it can get down in and ruin the tooth. And that, I mean, we all know that, right? Everybody's had those fixed. Pretty simple, thank goodness. Okay, so easy peasy teeth stuff. Any questions? Good. Pharynx is that common tube that I spoke about, okay, that food and water will pass through. The pharynx behind the nose is naso, behind the oral cavity is oral, behind the larynx is laryngopharynx. At that point, it splits. What tube is in the front? Trachea, and the esophagus is in the back. Okay? So air will go into, hopefully, the trachea, and food and water will hopefully go down the esophagus. Right? Okay? And the epiglottis, of course, we know closes off the windpipe to keep foodstuffs from going down there. Okay. The esophagus is a collapsed muscular tube. Now, couple things that are anatomically important about this. We can all swallow, right? And feel the swallowing at the top of our throat. And then do you think about it much after that? No. It's because the esophagus starts off as skeletal, and then it mixes in with smooth, and then by the end or the bottom or the inferior aspect is completely smooth muscle. And then that smooth muscle will continue down through the rest of the GI tract. You don't need to know, I go through it specifically, just know skeletals at the top, smooth at the bottom. You do need to know that the esophagus passes through the diaphragm at the esophageal hiatus. Okay, do I have that up there? Yeah, okay. So you'll see when we do the dissection, there's just a little hole through which the esophagus passes in the diaphragm. And immediately underneath it is the stomach. And what that does is the diaphragm actually helps to keep the top sphincter of the stomach closed so we don't leak acid from the stomach up to the esophagus. Okay. Okay, so that opening esophageal hiatus, it joins the stomach at the cardiac orifice at the gastroesophageal sphincter. So know that the opening is the esophageal hiatus, okay? Know that there is a sphincter there as well, because we want to keep the acid in the stomach. I would never ask you cardiac orifice. Okay. As far as the tunics, know that it has those 4 layers. Know that it changes from skeletal to smooth, as we said. Okay. The front part of the esophagus might touch serous membranes, but it's not encased in serous membranes. It has an adventitia around it. Okay. I don't think I'd ask you that, but here it is. Okay? So esophagus. Any questions about that? Okay. So the mouth starts to break down carbohydrates with amylase. This is one of our first enzymes. Usually at the end, if it ends in ASE, it's an enzyme, which will facilitate breaking something down or a physiological process. Mastication is chewing, deglutition is swallowing. That soft palate of the uvula closes off the nasopharynx. Hopefully we don't get food coming out our nose. Epiglottis closes off the larynx. This should all sound familiar, right? Okay. And the upper esophageal sphincter will close. There's actually one at the top of the esophagus. Okay. Keeping the food moving down. Stomach is basically a storage tank, but it has many physiological processes too to break down foodstuffs. A substance called chyme is made. Diameter will change with food. Did you know you can actually stretch your stomach out? I worked for a chiropractor years ago who, building up to Christmas and Thanksgiving, would start taking us to the buffet every week because he was stretching his stomach so he could eat more. I know, isn't that so funny? He was such a great boss. I miss him. On the other side, if you eat less, your stomach will decrease in size. So you do have, is it a huge amount? Of course not, but there is some elasticity to it. This is one of the problems with the stapling, the stomach stapling, is that they can staple it and people can start eating more and more and more, and guess what happens? They can stretch that stomach back out. So you do have elastic fibers that help with the size and shape of your stomach. On the inside of the stomach, so if we cut the stomach open, there's going to be rugae. And rugae are wavy projections on the inside of the stomach. And once again, wherever we have waves, we're increasing what? Surface area. So we have more exposure to whatever we bring into the stomach to digest it and break it down. The regions, I'm going to quickly go over, we'll be going over them in lab as well. Right as the esophagus comes in the stomach, I always thought of it as being like the turtleneck of the stomach, this area right here, like a turtleneck would be, right, on a person is the cardia, okay? It's called cardia because it's the closest part to the heart, somebody thought, even though that is, but, okay, so cardia. The rounded upper portion is the fundus. The majority is the body. Down right near the bottom is the pylorus. Okay. The pylorus is what feeds into the first part of the duodenum or small intestines. This can be narrowed in infants This is a very good clinical thing for you guys to do and learn because people miss this. When you have kids, they puke all the time. Hate to tell you. My kids, we'd feed them, they'd puke. We'd feed them, they'd puke. We'd feed them, they'd puke. We're like, how are you so fat as a baby? Because you puke all the time, okay? That being said, there are some children who puke profusely. They can't keep anything down. If they're puking and they're what do you think? Do you think that's normal? You're not with me. If they're puking, forget it, I'll just say it. If they're puking and they're not gaining weight, it's probably a narrowing of the pylorus. Write it down, it's called pyloric stenosis, S-T-E-N-O-S-I-S. Because there's some kids who eat and it gets here and guess what? It won't go any further and they puke it back up. If it's not getting into the small intestines, they're not getting nutrients. So if you have a child who's persistently vomiting and losing weight, they need to be checked for pyloric stenosis. This is missed more often than not. Okay? Not to know. Not that you can tell doctors what to do, but you can always suggest, right? So yeah, it gets here, it can't get any further, it comes back up. Okay? Are you with me? Pyloric stenosis. Okay? It's probably in the notes for you. Anyway, at this point then I'll pass through what's called the pyloric sphincter and into the small intestines. Are you with me? Okay. All right. Greater curvature is the bigger curve. Lesser curvature is the smaller curve. You're going to have mesenteries that come off those. Okay. Oh, and there they are. So there's greater omentum that comes off. This greater curvature is what I spoke to you about before. It's a double layer of those serous membranes. It has fats in it, it has blood vessels, it has lymphatics. There's also a lesser omentum which comes off this lesser curvature. Same thing, just much smaller, okay, different location, okay? Any questions on the stomach? Histology of the stomach. Okay. Has those 4 tunics. The Tunica Muscularis has an extra oblique layer to provide another layer of turning, right? So we move things. Now there's different cells. If you can imagine those simple columnar cells, there's deep gastric pits, okay? And along these pits, we have different types of cells with different type of functions. I tell you where they are. I don't care if you know where they are. They're like top, bottom, whatever. I want you to know what they do, okay? Mucous neck cells secrete mucus. Why do we need mucus in the GI or in the stomach?
Dissolve.
Yeah, so your stomach doesn't dissolve, right? You have acid and you have enzymes that break down proteins in your stomach. Those mucous neck cells secrete mucus that line the inside of the stomach to protect it. Okay? You okay? Okay. All right? Parietal cells are going to secrete hydrochloric acid and intrinsic factor. Okay? Hydrochloric acid will break stuff down. What does intrinsic factor do? It helps to absorb B12. Okay? Some people have a problem with releasing this, so they have to get injections of B12. Okay? Chief cells are going to secrete pepsinogen. Now, pepsinogen is the precursor to something called pepsin. Pepsin breaks down proteins. Are you with me? So what breaks down proteins? Pepsin. Pepsinogen is the inactive form. Why do we want to keep it inactive? Same thing we spoke about with the acid. Because pepsin breaks down proteins. What is our body made up of? Proteins. Okay? So pepsinogen stays inactive until we sense that we have protein in our stomach. It's turned into pepsin to break that protein down. So we keep it in an inactive form. Okay? There's more steps to it than that, but we're going to keep it basic. Enteroendocrine cells are, once again, along this lining. When they sense we have foodstuffs coming along, it'll send signals to secrete other hormones, which we'll talk about in the future, to help digestion, okay? And basically, those hormones trigger your gallbladder, your liver, and your pancreas to release substances, okay? And then we have a mucosal barrier, which is going to provide a layer of protection on the inside of the stomach as well, okay? Does that make sense? Yes, no? Good. Sorry, excuse me. So you can get ulcers in your stomach, you can get ulcers in your duodenum. And it can happen by a wearing away of the lining of the stomach or the duodenum. Somehow something went wrong and the acid gets onto the stomach lining or the duodenum and creates a little ulceration there, okay? Now, it can also be created by something called Helicobacter pylori. I was looking to see if I had the whole, everybody calls it H. pylori. It's a bacteria and it's a corkscrew kind of shape. So if you ingest it, like if you grew up on a farm, you're more prone to have been exposed to it. And it digs into the lining of your stomach and it creates an erosion there. And you have gastritis and signs of ulcers, right? Why is it important to know that it's a bacteria? What can it be treated with? Antibiotics. If you have anybody that has a gastritis, they should be tested for H. pylori because it's a simple treatment, okay? All right. You can get ulcers from not having H. pylori, okay? But quite often that's the cause. Any questions on that? We good? Cool. Okay, small intestines, so making our way down, okay? Major digestive organ, 20 feet cadaver, 10, actually I had 30 earlier, of course it's gonna vary a little bit, okay? We're gonna have duodenum, which is retroperitoneal, don't forget jejunum and ileum are the three major parts. The duodenum is a C-shaped curve around the head of the pancreas. So the head of the pancreas sits in the lap of the duodenum. Head of the pancreas sits in the lap of the duodenum. At that point, there's a little duct from the pancreas that secretes its digestive enzymes into the duodenum to help digestion. We also have a duct coming from the gallbladder and the liver to secrete bile at the same location, okay? So most of the digestive substances will be released right there. Right at that, so don't let this blow your mind, okay? Hepatopancreatic ampulla, easy. It's bringing stuff from the liver and the pancreas. The papillae is this little projection that pokes into the duodenum through which all the substances from the liver and the gallbladder and the pancreas go. Pretty easy. There's an accessory one too, I won't talk much about that. Inside of that papillae is a little sphincter. It's called the sphincter of Oddi, or the hepatopancreatic sphincter as well, okay? So big words, simple concepts. We'll secrete those digestive enzymes, and at that point, we start breaking down foodstuffs. Okay? Any questions about that? We're good? Jejunum is the next part. I have them wrapped together. 8 to 12 feet, most absorption is going to happen of foodstuffs along this point. They're both secured by that mesentery to the posterior thoracic wall, just like I showed you with a scarf. And you'll see when you dissect the intestines out in the cat that they're held in place, but they're movable. Because we want these to move because we want to turn foodstuffs in them. Okay. They will then connect to the large intestines at a little C-shaped curve I'm going to show you in a minute called the cecum. This is an important anatomical structure for you to know. There's an ileum, cecal, cecum valve at that point. If somebody needs a bag, they'll put it in that location. That's why you should know it. And there's a little valve in there that will let that broken down food move from the ileum into the large intestines. It's also where your appendix is. Okay? So it's a good landmark, ileocecal valve. Inside of the small intestines, don't forget we have those 4 layers. We have simple columnar. But we have some other things to increase surface area because we want to increase the surface area here greatly because we're absorbing most of our nutrients here. We have wavy. If you actually open the tube up and look inside, we have waves which are called Plicae circularis. They're just ones you can just see with your eyes. We also have finger-like projections like the nap of a carpet called villi, increasing surface area. And guess what's on top of the cells themselves? Microvilli. So we have a lot of those increase in surface areas in the small intestine so we can absorb a lot of nutrients. Inside of those villi is a little, so if you imagine that finger-like projection, inside each one of them is a little capillary and a little lymph vessel, and they're just sitting there waiting for what? What are they going to do? Can you picture that in your head? So if we have this little villi, or finger-like projection in the GI tract, there's a little lymph vessel and a little capillary. What's passing by this villus? No? Let me back up. If I have food in the tube of my small intestines that I'm trying to absorb, and if you think of those villi sticking up, and in each one is a capillary, each one of those is going to be absorbing what? Nutrients. It'll move through the capillaries in the lymphatic system and move into the hepatic portal circulation, and from there it goes into the liver. Are you with me? Okay. Yes, no? Okay. That's what that little lymph and capillary vessel are doing at that point. Okay. All right. Does that make sense? Any questions on that? All right, moving on. So, Peyer's patches are collections. It says lymphatic follicle is basically white blood cells. And these are found in the submucosa of the ileum, okay? Yeah, of the ileum. I was making sure I had it there. And what these do is help to protect us against infectious agents, bacteria and viruses, okay? In the duodenum, and that's back where? Right next to the stomach. So if the duodenum is getting things from the stomach, they're going to be very what on the pH scale? Very acidic. There's duodenal glands which will secrete bicarbonate. So we secrete a little bit of substance from the stomach which is acidic, mix it with the bicarbonate. There's some coming from the pancreas too. That neutralizes its pH. We secrete a little bit more, do the same, all right? These duodenal glands help to produce the alkaline substance. Okay, does that make sense? We gotta calm down that acidity. I don't know why I put it with Peyer's patches, because it's completely different. Anyway, liver and gallbladder. So the liver has 4 lobes, lots of blood, right? We're going to be bringing all that nutrient-rich blood, the liver's going to be processing it and then sending it out to the body. Once we get that nutrient-rich blood, guys, from the liver, or from the intestines to the liver, are you with me? Can you picture the liver in your head? Just behind the liver is the inferior vena cava. Can you picture that in your head? And where's the inferior vena cava go? Goes to the heart. She goes like this. Heart, okay? Your inferior vena cava goes to your heart. Okay, so we have nutrient-rich blood in the liver, goes to the inferior vena cava, which goes to the heart, and then the heart sends that nutrient-rich blood where? To the body. Isn't it brilliant? Okay, isn't it brilliant? I think it's brilliant. I think it's pretty cool. Okay, so that's where we're going. So this liver is very blood rich. It's constantly processing nutrients that are coming through. There's 4 lobes, right, left, caudate, quadrate. Take a look at those when you have a minute, okay? Now, there's ligaments. There's a falciform ligament, which is between the right and the left lobe. And that ligament comes on and attaches to the front part of the body. But there's also something called a round ligament, which we don't see. Because that round ligament comes down to the umbilicus, and guess what that's left over from? We don't see it because we cut it off as we open the abdomen, but guess what it's left over from? What do you think? It's gone to the umbilicus. Probably has something to do when you were in your mom's stomach. Umbilical cord. It's leftover umbilical cord. Used to come in, go to the liver, to the heart, and be pumped through. We'll go over that in embryology. Okay. So round ligament. Okay. Hepatic artery is going to be the artery which simply provides the liver with good, fresh, nutrient-rich blood so the liver can regenerate itself. Right? Because the liver is a living tissue. Do you know you can regenerate your entire liver within 7 years? Okay, the liver is very healing and regenerative to a point. Okay, portal vein is part of that system that brings nutrient-rich blood from the intestines. Okay, so that's on the back part of the liver as well. Are you with me? Okay. Then there's going to be hepatic vein, which is going to drain the liver itself, but that's, I even left that out. I don't know why I put cut there. It's just a typo. That should be duct. Okay, cut, cross off cut and put duct. Okay, the hepatic duct will come off there. Okay. Just keep in mind that the liver is going to process nutrients, but the liver also creates bile. Bile has to come out of the liver, and I know they subdivide it, we're just going to go with hepatic duct, okay? Through the hepatic duct, and I'll show you the next couple steps in a slide or two, okay? And what does bile do? Breaks down fats, okay? So bile from the liver is going to help to break down fats. And it actually emulsifies it, it's called. Oh wait, talk about the ducts here. Okay. So if we, one second, let me look at something really quick. What's going on? Okay. We're going to go back 1, 2, 3, 4, 5 pictures. Hold on. Yeah, we're going to go back. Because it's important for you to understand this duct system. Okay? So the liver creates bile. Okay, the liver creates bile. The bile comes down hepatic ducts, right? Hepatic means liver. And it can either continue down into that hepatopancreatic ampulla into the duodenum, or the bile can go back up and into the gallbladder. Agree with me? It can go 2 places. It can either go down to the duodenum or it can go back into the gallbladder. Okay, and the gallbladder will just store bile. It doesn't create it, it just stores it. Are you with me? So the duct coming from the liver is going to be hepatic. There's right, there's left, there's common. As long as you know hepatic, I'm good with that. Cystic comes from the gallbladder, or goes to the gallbladder. And then common bile duct is where they join together. So hepatic, cystic, common bile duct. The common bile duct will then go to the duodenum. Are you with me? The reason it's important to understand that ductal system is because people can have their gallbladder removed, right? Has anybody had their gallbladder removed? No? You can have it removed and you can function perfectly fine without it because the bile will come directly from the liver to the duodenum. Or what can happen is you can expand this duct a little bit and the liver will store it in the expanded duct until it's ready to be released. Okay? So it's important to know those steps of the duct system to know that this can be removed. Yes? Okay? All right. Okay, so common hepatic duct joins with cystic duct to form common bile duct. Is your liver on the right or left? Is your liver on the right, anatomical right or left? We'll look it up and know it. Okay. All right. If we, and when we go into lab and look at the liver microscopically, it is actually in these really cool 1, 2, 3, 4, 5, 6-sided structures. It organizes liver cells, and the liver cells are called hepatocytes, into this formation. We bring nutrient-rich blood in. It'll filter through all these cells. It does a multitude of things, which we will list off in a little bit. Goes into this central vein. Eventually, those combine and form the nice big hepatic vein, which will go into the inferior vena cava. Okay? Are you with me? Now, also among these cells, do I have Kupffer? I do. Among these cells, we have Kupffer cells, which are macrophages. So if we do get bacteria and viruses that come in, those Kupffer cells can eat them up and process them in the liver. Those Kupffer cells can also process toxic substances. Liver, if we ingest some kind of, thing that's not good for our body, Kupffer cells can break those down. Okay? Hepatocytes also create bile. That bile will be pushed actually from the center out. Goes 2 different directions. That bile then goes into a duct system, which will lead to the hepatic duct. Okay? All right? Are we good with that? Does that make sense? Yes? Okay. Liver produces bile. Stores glucose as glycogen. Do you remember that? It's our main storehouse for glycogen. If we don't have enough glucose in our diet, we can cleave it off those glycogen bonds in the liver and use it for energy. Okay. It uses amino acids to make proteins. Our liver will take amino acids from the foodstuffs that we eat, combine it together and form new proteins for the body. Okay. It stores fat-soluble vitamins. I'll teach you what those are next week. And it helps detoxification. That's what those Kupffer cells are for, those macrophages. Okay? There's a ton of stuff. And we're actually going to go into more of what it does next week. It's super important. This is why if people have a sick liver, they're very sick. Because it does so much. So let's talk about bad livers. Okay. Hepatitis. There's multiple forms of hepatitis. It's a viral infection. Okay. When we talk about A and E, it's enteric. Students love to hear about this. Who's taken micro? What's enteric? Okay, it's fecal oral. Ugh, right? It's a chef who has gone to the bathroom and not washed their hands and prepared your salad. Right? You can get it that way. Now, B and C are bloodborne. So this would have to be a bodily fluid contact, usually injection of some sort, okay? sexual transmission. There's some way that blood has been transferred from one person to another with B and C. This leads to a chronic hepatitis. Okay, A&E you're going to get over. You're going to get sick. You're going to have flu-like symptoms. You'll be better in a week or two. Your body can process that. B and C causes what's called chronic hepatitis, which will be a chronic inflammation of your liver. Okay, it's kind of nasty stuff. I think they have better medications to deal with it at this point, so it's not as bad as it used to be. Now, what you're probably going to see more of is cirrhosis. Okay, cirrhosis is damage that happens to the liver. Remember I told you your liver can regenerate itself to a certain point. If you're pounding 5-10 drinks a day, I mean alcoholic drinks, if you're taking a lot of Tylenol or Advil on a regular basis, if you've been exposed to a toxic substance, your liver will regenerate to a certain point. At some point, it will stop regenerating. And those hepatocytes will either turn into fat or scar tissue. At that point, the fat and the scar tissue is not going to turn back to normal hepatocytes. You lose more and more of the good parts of the liver, and eventually it can turn from a nice, smooth liver into this really bumpy, lumpy, gross-looking thing here that's full of fat and scar tissue. Do you think this person's going to do real well? Absolutely not. Okay. So this is why moderation with drinking, medicine, and even fatty foods. If you eat tons and tons and tons of fatty foods, you can make your liver look like that if you become grossly obese. And I don't mean gross, disgusting. Grossly obese is an actual term for people who are morbidly obese. I think they've changed it to morbidly obese at this point. Okay? All right? So cirrhosis, blah, blah, blah. Now, if we have cirrhosis like that, blood can't come from that portal vein. Remember what the portal vein does. What does a portal vein do? It brings nutrient-rich blood from the intestines to the liver. Are you with me? This is an important clinical thing. Okay? If that portal vein cannot get the blood into the liver, it's going to back up into the portal vein and cause pressure in the portal vein. That is called portal hypertension, when you have that excessive pressure in that portal vein. Okay, portal hypertension. That'll back up and you'll actually get distended blood vessels radiating out from your umbilicus that look like hair. It's called caput medusa because it actually looks like Medusa's hair coming out from your belly button. Isn't that crazy? Or it'll back up and it'll cause distension of the veins around your esophagus and people can start spitting up blood. Hemoptysis. Okay. I was interning at Bassett years ago in their ER, and somebody started doing this. And I don't know if it's from portal hypertension or not, but it wasn't like a little bit. It was like vomiting blood because one of those esophageal veins had burst. Okay, so but that can come back from cirrhosis. Okay, and if somebody is sick, and a little byproduct note here, a little sidebar, I should say. If somebody's sick enough to have a liver like that, guess what the rest of their body looks like? Do you know what I mean? They start to get all these crazy symptoms that might seem disjointed, but they're probably all coming back just from their general health. So anyway, all right, I'll say no. Okay, so bile is yellow-green, it's alkaline. There's bile salts, pigments, cholesterol, fats. I'm going to start moving because I would like to finish these slides. It helps to emulsify fats. Do you know what an emulsifier is? Probably not. If you take two salad dressings and one has oil and vinegar in it and the other one is oil and vinegar but it's mixed, that has an emulsifier in it. It's usually lecithin. Okay, bile acts like that for us. It'll emulsify fats so your fats don't separate out in your bloodstream because blood is what? Mostly water. Okay, so bile acts as an emulsifier to spread the fats out in your bloodstream. There's also phospholipids, which is a combination of phosphorus and lipids. It's actually recycled by what's called the enterohepatic circulation. So bile salts will be reabsorbed at the ileum and returned to the liver. That's an important thing to know because some new cholesterol medicines will actually stop that process from happening and get rid of some bile salts, and by getting rid of that, we get rid of some of the fats in our body. Okay? Gallbladder, green muscular sac under the liver, stores that bile, doesn't make it. It's stimulated by something called cholecystokinin. That's a hormone that's released to the blood from the duodenum. And there's another thing that stimulates it, but just know that cholecystokinin is an intestinal hormone released to the blood from the duodenum that stimulates gallbladder contraction and also the release of pancreatic enzymes. Okay, I would add that on there. And the release of pancreatic enzymes. Okay, cholecystokinin. Okay. Any questions on that one? Am I going too fast? No. Gallstones, also known as biliary calculi, I don't think anybody calls it that, but the cholesterol will crystallize and form little crystals, and you know, they almost look like little marbles, right, within the gallbladder. You can have one, you could have multiple, you could have one pass it and then you're fine, or it breaks down. Some people can be really prone to them and have more of them, so they have to have the gallbladder removed. I think I passed one point, and I mean, I think of myself as being a pretty strong woman. I literally was crawling on the floor calling my husband at work saying, like, you need to come get me, there's something wrong. And it lasted for like 6 hours. Like, I probably should have gone to the ER, but it sort of waxed and waned a little bit, and then finally it just passed. And it was right where you get gallbladder pain. It was right in this location. And I'm telling you, it was worse than childbirth. It was the worst pain I've ever had. I had a friend who had one attack and she had her gallbladder out. She's like, I'm done. I'm never doing that again. Then maybe mine just dissipated or moved, because it
tries to pass and it gets stuck.
Yeah.
And that's the pain. You had a stroke. It's so bad.
It was so bad, wasn't it? Yeah. So I don't know if mine dissipated, or I figured maybe it wouldn't pass, but I've never had it again. I can't imagine. So, but I'm telling you, I was almost ready to call 911. The only reason I didn't call 911, I'm telling you, is because my kids were home with me. You know, so. Awful. I don't wish that on my worst enemy. Okay, so pancreas. Okay, head of the pancreas sits in the lap of the duodenum. It's retroperitoneal. We know this. I'm going to buzz through it. Releases exocrine and endocrine substances. This you should know. Acini are round clusters of cell that create and release the digestive enzymes. Acini. Okay, so that's plural. Acinar cell, multiple acinar cells create acini. And you'll see them, we'll look at them when we look at the pancreas microscopically. They form a little round unit. They create and release digestive enzymes to a small duct, to a bigger duct, and eventually out to that large duct that we looked at goes to the duodenum to secrete those digestive enzymes to break down foodstuffs. The islets of Langerhans, we know, release glucagon and insulin. We talked about that in endocrine, just as a little reminder. There is a main pancreatic duct, which is pretty much what we'll talk about. There's also a supplementary secondary one, okay? Large intestines absorb water and secrete feces, okay? Okay? It also helps to create some vitamins, which I have a little bit further along. If you look at so this is pretty easy. They're just big words. The haustra are the pockets. See how it has those pockets along the length of it? Okay. Instead of having this smooth muscle like a tube that we had in the previous parts of the intestine, it actually comes in strips. And those strips are called Tunica coli. See how there's a strip of smooth muscle here? I believe there's 3 of them. Okay, so instead of having the whole tube, we have these 3 sort of strips of smooth muscle. And hanging off the intestines, we have these epiploic appendages. They're little finger-like projections of fat I have no clue what they do, I'll be honest with you. Okay, I think that they don't do anything. It's just where fat deposits on this large intestines. So the hostra, the outpocketing, the tenae coli are those strips of smooth muscle. Epilogue appendages are finger-like fat productions. Okay. I think it's a little more important to know these structures. As the small intestine comes down, the ileum connects at this C shape, which is called the cecum. Okay? So the cecum is where the ileum connects in at the ileocecal valve. At this location off the cecum, we have the finger-like projection of the appendix. Okay, that's an important structure to know as well. At that point, we have ascending colon, transverse colon, descending colon. Sigmoid colon is the S shape. As the sigmoid straightens, and you'll see on the cats, it gets into the pelvic basin, it turns into the rectum. At the very end of the rectum, like the last half an inch to an inch, is the anus, which is the sphincter that closes it. There's actually two sphincters. There's an involuntary and then a voluntary, okay, with the anus. Now, so are we good with those parts? Okay, it's easy stuff. There is a right and a left flexure. Hepatic and splenic is another name of it. I would make note of those because you might see them, see on a CAT scan, that'll be an earmark of the corners of the large intestines. Okay, so hepatic and splenic flexures. Okay. There's a transverse and a sigmoid mesocolons. All that means is that there's a mesentery there holding it to the back part of the abdominal wall. Okay. Oh, and then internal and external anal sphincter. I spoke about that. Am I going too fast? I think that's all pretty easy stuff. By all means, if you have a question, let me know. Now, the mucosa of the large intestine has lots of goblet cells because we take a lot of the water out, so we want to be able to pass feces without discomfort. Okay. There's bacterial flora, which helps to produce vitamin B. It's B6 and vitamin K. Just no B. I think there's actually a couple B vitamins, but B and vitamin K is sufficient. 500 milliliters of gas is produced every day. In my house, you could probably quadruple that. My kids are unbelievable tutors. Anyway, motility of the large intestines. Those little hastra can contract and push foodstuffs along. We have major contractions 3 to 4 days to force contents to the rectum. Okay. Is that the same pattern? Then I'm like talking about poop. So I don't want him to walk in. I'm like, I'm feces. It's moving. Anyway, so and this varies from person to person. There's something called gastroileal and gastrocolic reflex. When food hits your stomach, it stimulates your ileum or your colon to create a bowel movement. And then we do that to keep things moving along. This varies from person to person. It might be once a day, it might be twice. I know this says 3 to 4 times a day. If you're not going 3 to 4 times a day, don't stress about it. Okay, this varies greatly. There are some people who go every 5 days. There are some people who go twice a day. So this varies, okay? But we do have reflexes, and when food hits the stomach, it tells the colon and the ileum to sort of, all right, let's move things along. Okay, so we're bringing in more food. Okay. Diverticula. We only have a couple. Oh, beautiful. Okay. I know this was a bit of a rush, so let me know if you have any questions. Along the large intestines, especially along the colon and the descending colon, we can get outpocketings. We get weakenings of the colon wall, and you could get little pockets called diverticula. Those diverticula can get feces. Some people say seeds or nuts can get stuck in them. If they get stuck in there, they can get infected and you can get diverticulitis. Okay, are you with me? So diverticula are the pockets. Diverticulosis is someone who has pockets, right, in their colon. Diverticulitis is when those pockets become infected and inflamed. Okay. This is excruciating if you've ever had it. Okay, diverticulitis. So, do you have a question? Oh, okay. All right. Now, diarrhea and constipation, it's how fast or slow things are moving through. Okay. Rushing of food through the colon causes diarrhea. This could happen if you've eaten something that your body doesn't agree with, if you get some sort of infection, your body knows, whoo, let's get this out. It doesn't have enough time to absorb water from that foodstuff, so that's why you get diarrhea. Constipation is the complete opposite. Things are stuck in the colon for so long that all the water gets absorbed, and that's why they'll give you medication like an enema or something that'll draw water back into the colon to push things through, okay? I think that makes sense. Appendicitis. You saw where the appendix joins into the cecum. At that opening, you can actually get feces blocked in it. And if it stays in there long enough, the appendix can get infected and inflamed, and you get appendicitis. The pain for appendicitis starts, I'll tell you right now, anything in the abdomen starts in periumbilical, because what happens is the structure needs to get infected and inflamed enough to touch the outer wall for you to localize it. Are you with me? That's where your pain receptors are. So if you start with a general inflammation anywhere in the abdomen, you're kind of like, yeah, I don't know where this is and I don't feel good, kind of thing, until that appendix is so inflamed it'll touch, and then you're like, oh yeah, it's right here, okay? Same thing with diverticulitis. You start with this generalized pain until it gets so swollen it touches the abdominal wall, and you're like, oh yeah, it's right here. See what I'm saying? Pancreatitis, same thing. Gallbladder, same thing. It needs to be swollen and infected enough to expand to touch the abdominal wall, okay? You do get those weird referred pains too, which would be a good thing to review. Now, the bad thing with the appendix, guys, is if it gets infected and inflamed and you don't get it taken out, it can burst. And if it bursts, all that infection now gets into your peritoneal cavity. That's bad news bears. Okay, so you want to make sure you get that taken care of. Never be a hero with your appendix. Okay, all right, chemical processing. So carbohydrates. Pancreas is misspelled. Somehow I put the wrong spelling into my spell check. So then when I was buzzing through, crossed the E off, okay? So I think I sort of linked them together so you can maybe tie in how to break down things a little easier. Carbohydrates are primarily broken down by amylase in the mouth and amylase from the pancreas, not pancrease, cross the E off. Okay, now lactose intolerant. There are some people who don't have the enzyme to break down milk. So when it's not broken down, it stays in your intestines, it draws more fluid in, and you get that response of diarrhea. Okay, very simple. You can actually take enzymes to break those down, or pick substances like milk that's made with enzymes that make breaking down the milk easier. Okay, that's called lactase, is the enzyme. Proteins are broken down into amino acids by pepsin from the stomach. Okay, there's other steps, we're just going to go with that. Lipids are emulsified with bile salts into fatty acids and broken down by lipases from the pancreas, across the off again. Now nucleic acids are broken down by pancreatic nucleases. Don't forget, nucleic acids are going to be found anywhere. RNA, DNA, we need those to make our RNA and DNA. Okay, does that make sense? I think that's pretty simple. Okay, absorption. Mostly in the small intestines. Remember, the ileum is going to reclaim bile salts. We absorb carbs, proteins, nucleic acids, and lipids in the small intestines. We're going to reabsorb water in the colon. Okay. Celiac disease. So an example of malabsorption of nutrients, as well as those other diseases that I interspersed throughout the lecture. Another example is celiac disease. People with celiac disease have an intolerance for gluten. And what that gluten actually does, I think we're all familiar with this. People who have true celiac disease, it will actually destroy the villi and the microvilli. So if it destroys the villi and the microvilli, they can't absorb things as well, right? Because they don't have that increase in surface area. Okay. Diarrhea, obviously, things will go right through them. Pain and malnutrition because they're not absorbing substances. This is the last thing. Good. Okay. This will take me just 2 minutes and then we'll be done. Okay. And this is from the endoderm. Remember we talked about endoderm, ectoderm, mesoderm. GI tract is going to be endoderm. Okay. Cleft palate we spoke about is the non-fusion of the hard palate. And that could go maxilla all the way back to the palatine bones. Bread and butter stuff, you should know that. Cystic fibrosis is an awful disease, genetic disease, where there's an overproduction of mucus. And everybody knows the signs with the lungs because people can't breathe well because they get mucus in their lungs, much like you would with a bronchitis. But they can have an overproduction of mucus in the pancreatic duct as well. So if that happens, they can't get the enzymes out from the pancreas into the duodenum, so they can't digest their food. So they tend to not be able to absorb nutrients and get very thin and weak with cystic fibrosis. The good thing is, though, they can take digestive enzymes, which is very helpful for them. The rooting reflex is that reflex of a child to root for the nipple when they are nursing. Okay. It's one of the reflexes that is anybody going to go into labor and delivery? No? It's one of the reflexes that you would test to make sure that a baby has the appropriate reflexes. During old age, digestive juices are slowed. You can't absorb as well and break things down as well, and that's why us old people, much like your parents do, reach for the what after dinner? Tums, right? Because we can't digest and break things down as well, unfortunately. Okay, old age is fantastic. All right, that's digestive system in a nutshell. Thank you very much. We'll see you guys next Monday. Email me if you have any questions. Good luck on your lab exams if you haven't taken them yet. Have a great week.